Kia ora toto everyone. Welcome to this Goodfellow Unit webinar. I am Dr. Helen Fulcher, a GP and your Goodfellow moderator this evening. The webinar tonight is on Demystifying the Spine, a primary care approach to the adult and paediatric spine with Dr. Anand Segar. Dr. Segar is a New Zealand and internationally trained adult and paediatric spine surgeon working at Starship Children's Hospital in Auckland as well as in private practice. He has a PhD from the University of Oxford, where he examined the relationship of obesity and low back pain, and has completed 3 spine surgical fellowships in the United States. Dr. Segar has received numerous awards for his research, serves as deputy editor for the journal Clinical Spine Surgery, and is a senior lecturer in surgery at the University of Auckland. This webinar is also kindly supported by Mercy Ascot. We welcome your questions tonight throughout the webinar, and as always, we'll endeavour to get through as many questions as possible in the time available. And so welcome, Anand. I will hand over to you now.
Good evening. Thank you very much, Helen. It's a pleasure to be here. Thank you to the Goodfellow Unit and to Mercy Ascot for supporting this. So as Helen said, my name's Anand Segar. I'm an adult and pediatric spine surgeon, so I focus on the spine from top to the bottom from all age groups. And I work up in Auckland at Auckland Hospital, Starship, and also in private practice. So what I wanted to do today is just give everyone an overview of the spine. And I think it's quite challenging for non-spine surgeons, non-orthopedic surgeons to get a grasp of the spine, and it worries a lot of people. So hopefully this can simplify a lot of things and give you ways to deal with spine problems. So today what we're going to cover is back pain. We can't go far talking about the spine without talking about back pain. We're going to talk about red flag conditions, radiculopathy, stenosis, and spinal deformity. So we're going to talk about the neck and the low back, as well as spinal deformity in adults and children. So if we look at low back pain, this is the 2010 Global Burden of Diseases study from the Lancet. And the #1 cause of worldwide disability, years lived with disability, was low back pain. And that held true if it was in low-income, high-income North Africa, low-income Asia, or the United States or New Zealand. And the 4th cause of disability was neck pain. And that ranks higher than diabetes or road injuries or epilepsy. So it's quite a morbid condition and costs us a lot of money. It's the 8th most common presentation to GPs and affects patients of all ages. Unlike other chronic conditions like diabetes or ischemic heart disease, which generally affects older adults, it affects males and females. And going from 1990 to 2019, the disability that people experience, the DALYs, have increased. So over those 3 decades, the disability from back pain has increased. Most of the back pain, thankfully, is non-specific and benign, and most will get better. And I explain it to people as the back pain of life. It is associated with huge costs. It costs Australia $8 billion, and that's indirect costs. So that's the cost to the economy for people suffering from back pain, and only $1 billion of that is direct healthcare costs. So what is mechanical low back pain? Well, mechanical low back pain is back pain arising from the back itself, above the waist, and radiating to the thighs, not below the knees generally. It arises intrinsically from the spine. And one of the challenges we have with the spine is, where does the pain come from? So what we have here is a model of the spine, and we have muscles, we have bones, we have ligaments, we have joints, we have discs. So trying to identify where the pain comes from is very, very challenging. The pain is often recurrent. So one episode of pain is often met with another episode of pain in about 25 to up to 80% of people within 1 year. And most of it's non-specific, which makes it challenging. There's no defined anatomical or pathological cause. But thankfully, most of it has a benign course. So non-specific back pain is a symptom, it's not a disease, and it's low back pain without a clear defined patho-anatomical cause, so it's benign. And only 1 to 15% of patients will get a clear diagnosis. Acute episodes, the recovery is time dependent and can take a lot of time for some people. 50% recover at 3 weeks, and that's a study from the Lancet in 2014. But only 72% recover at 1 year, and this is 1,100 patients presenting to primary care in Sydney. Their pain scores trend down. If they're going to recover, they trend down from 5 to about 2.3 at 6 weeks, and half again at 26 weeks to 1.2, and half again at 1 year to 0.6. And that's a systematic review from the Canadian Medical Journal. But in those with persistent cases, their VAS scores kind of stagnate from about 6 weeks to 1 year, sitting at about 2.5. So people are living with some background pain. And the poor prognostic factors of people to not recover from back pain are high initial disability, increased psychosocial distress, older age, poor general health, negative cognition, heavy physical work, and the presence of compensation. So in our population, that often looks like, to patients that I see, older, heavy manual laborers who spend a lot of time working, not a lot of time looking after their own health, who have ACC. So those are the people that may not get better from an acute episode of back pain. So how do we manage back pain acutely? Well, the management is focused on reducing pain and disability. There's no underlying cause to treat, so it's just trying to manage the symptoms and help them through the recovery process. Managing their beliefs and fear about pain, and explaining that the medically serious cause is very unlikely and imaging generally is not necessary. And I imagine that's easier said than done in primary care, easier for me to say than it's done when you're faced with a patient. Managing fear avoidance beliefs and pain catastrophizing. So this is the fear avoidance cycle, and patients enter with an injury, and depending on how they respond to the pain experience, they can either catastrophize the pain, think it's the worst thing ever, think that they're going to die or become paralyzed. That's often a thing that patients present to me with. If I haven't done anything because I'm worried that if I keep moving, I'm going to become paralyzed. They catastrophize the pain and they get scared of their pain. They get avoidant of their pain. They get depressed. They stop moving, and then they cycle around. And it's really hard to get them off the cycle once they're on it. Whereas if we can manage their pain experience appropriately, get them into the low fear side of things, they're more likely to recover. And I try, as I've said before, to explain it to them as the back pain of life, and they're not going to come to any harm by doing it. They're going to aggravate their symptoms, but they're not going to make the symptoms, they're not going to make any underlying, generally any underlying problem any worse. And in primary care, education is the key. And this came from a JAMA article in 2015, that education and reassurance in primary care does provide long-term reassurance to patients. It reduces subsequent visits to primary care. And the education is better when it's from a GP when compared to a nurse practitioner or a physiotherapist. Activity doesn't worsen the disease. And there is some evidence for low quality evidence, but it does provide a large magnitude, even though the studies are not good. But I imagine through all of that, this is often what you're faced with in primary care. You provide all the reassurance and all the evidence and the thoughts that things aren't going to get worse, and the patient still says to you, is there anything else you can do for me? So what about the pharmacological management? Well, paracetamol is often a medication, the medication, first-line pain relief that we prescribe for patients with any pain. 2 randomized control trials of nearly 1,800 patients showed that there was no effect of 4 grams a day of paracetamol compared to placebo at 1 week, 2 weeks, 4 weeks, and 12 weeks for pain, function, quality of life, patient's impression of recovery, or their sleep. So really, paracetamol has been debunked in acute low back pain, except the American Association of Family Practitioners suggest that synergistic effects, so the effects of paracetamol with a non-steroidal, may justify its use despite its lack of high quality evidence. So paracetamol and ibuprofen can avoid low dose or opioid use. So other medications, non-steroidals, so there is no difference in the type of non-steroidals in outcome, and the general advice is use it at the lowest effective dose for the shortest time. And Norflex is a medication that I've seen prescribed quite a lot recently since I returned from fellowship about 2 years ago. And it's not one that I was aware of. So I looked into it, and the mechanism of action is not really well understood. It has anticholinergic, histaminergic, and NMDA receptor actions, but the evidence for back pain is poor. A RCT in the Annals of Emergency Medicine showed no benefit when they combine it with naproxen, and the side effect profile makes it difficult to use, especially in older patients with glaucoma, BPH, or ulcers. So if we're looking at non-pharmacological management, one of the goals is to identify poor responses. So responders, physiotherapy, acupuncture, all have low harm, but high cost if you prescribed it to absolutely everyone that came into your practice with back pain. So how can we identify people who are not going to do well? So the Orebro questionnaire is one way that we can, and this is a questionnaire here, which probably in a time-starved practice is difficult to administer, but asking the questions may be easier. So asking questions on pain, how would they rate their pain? How would they rate their function? How would they rate their sleep, whether they're depressed or anxious about the pain, and what they feel their thoughts are or their beliefs are on returning to work. And a score in the questionnaire of 50 suggests a high risk of future disability, and those patients may benefit from a early referral to physiotherapy or some other allied health service. There's also the Keel Start Back screening tool, which follows similar principles. And in practice, it might be easier to utilize the questions and get a general gestalt for how the patient's doing rather than applying the questionnaire itself. So we look at the evidence for non-pharmacological intervention. So physiotherapy, this is from a Cochrane review. These next 4 points are all from Cochrane reviews. There was no benefit for acute use less than 6 weeks. So that really just goes to the fact that it's all about education and managing patients' beliefs and their symptoms through the acute course. Subacute exercise therapy, improved return to work, and chronic back pain, so greater than 12 weeks, it was only a slight improvement in pain and function. If you look at manipulative therapy, so chiropractor or osteopathy, it was no more effective when compared to sham or education. Acupuncture, again, there was low quality evidence for immediate improvement in back function, and there was no improvement in pain or quality of life. And finally, massage, there was very low quality evidence for very short-term improvement. And I think if you talk to patients, they will say that they feel great after massage, but the pain comes back about 4 to 6, 12 hours later. This doesn't mean that none of this is useful. It's probably useful in selective patients. We all have patients that visit a chiropractor and get great benefit from chiropractor or osteopathy or acupuncture or physiotherapy. So everyone's different, but in general, the overall body of evidence would suggest this, which was interesting for me to figure out. And physiotherapy is not just physiotherapy. You have to ask your patient what physiotherapy they're getting. What you want is a guided and focused exercise and core rehabilitation program. What they often get is some of the above, but also massage, light therapy, needling, which doesn't work if it's used by itself. So they usually use as adjuncts. And I sometimes re-refer patients to different physiotherapists if that's what they tell me that they're getting. Invasive treatment for non-specific low back pain. Well, there's no evidence for any injections, facets in the epidural space, the facet joints, steroid, anesthetic, nothing for non-specific low back pain. It doesn't work. And similarly, nothing that I can do as a spine surgeon can help patients with non-specific low back pain other than reassure them and tell them that there's nothing wrong. So when should you refer patients with back pain? Well, back pain in isolation rarely requires referral, rarely needs to see a spine surgeon. Very rarely isolated disc disease can be treated with surgery, but that is in the absolute minority of patients. But so who can help? Well, I find these patients challenging to deal with as well, because I don't have the skill set to help them as a spine surgeon. So I often refer these patients to musculoskeletal specialists, and they provide such a great service for my practice for patients with non-specific back pain, because they have the tools to manage this back pain without surgery, with education primarily. So we talked about non-specific back pain. So what about the symptoms that should make you worry? Well, these are the red flags that we're all taught about from med school or nursing school, and there are 4 causes for red flag symptoms. I break it down into 4 causes. It's cancer, fracture, infection, and cauda equina syndrome. So we take each one individually. So cancer, most of the cancer to the spine is metastatic, and spine is the most common bony site for metastases. If we're thinking about the patient's history, a strong predictor or something that would make you worry about metastatic cancer to bone is someone who has known metastatic disease to the bone. Unexplained weight loss is also important, and weak predictors of cancer diagnosis to the spine would be a history of any cancer, pain not relieved with rest, and night pain. So night pain has a false positive rate of about 60%. And this is an MRI scan, and you can see those hot spots there at the top in the middle. They are metastatic cancer. So fracture, this is a CT scan of a thoracic compression fracture, a CT spec scan. You can see the body is wedged and it's hot and orange. The cause of fracture is either traumatic, so a heavy external force, or pathological. And pathological fracture means abnormal bones. That's osteoporosis, rheumatoid arthritis, or ankylosing spondylitis. So someone that has a significant trauma would make you worry, and that's age appropriate. So a fall from a standing height in a 25-year-old male shouldn't be as worrying as a fall down 2 steps in an 80-year-old female. Prolonged steroids and a history of osteoporosis is also important. And an age greater than 70 by itself is not in isolation, shouldn't worry you too much. The examination findings is really percussive tenderness. And if someone has a history of an ankylosed spine, so ankylosing spondylitis or diffuse idiopathic skeletal hyperostosis, that's the acronym's DISH. If they have pain and an ankylosed spine, that fracture is easily missed, and they should have advanced imaging. So that's someone you should be referring through to the hospital for advanced imaging. I thought I'd put this in here. It's more of an emergency medicine thing, but also relevant to primary care. For patients with cervical spine injury, imaging is not always indicated. So we use the nexus rule. So imaging is indicated only if they have one of the 4: midline tenderness, a focal neurological deficit, if they're obtunded, intoxicated, or if they have a painful distracting injury. They get a 3-view cervical spine series, AP, lateral, and open mouth, and you got to make sure the lateral goes down to C7T1. And that has a sensitivity of detecting an injury in 99%, so very low false negatives. Infection would be discitis, osteomyelitis. I think these have died.
So things that in the history that would make you worry would be a history of severe pain or recent spine surgery. So someone that's coming to see you after spine surgery, you'd think about a deep infection or superficial infection. Someone who is on uses IV drugs, which is uncommon in our country generally. Immunosuppression or distant surgery. So someone that's had surgery, say, a year ago. A weak predictor would be pain not relieved with rest. They would have fevers and wound complications if they've had recent surgery. And percussive tenderness is also an important finding. Generally, if the bloods are normal white cell count, CRP or ESR, it's unlikely to be infective. So cauda equina syndrome is something that we all worry about, and rightly so, and it's a constellation of symptoms. It's generally a large space occupying lesion in the spinal canal, usually a disc herniation, but could be a tumor, spinal stenosis, a bleed, a spontaneous epidural hematoma, or post-lumbar puncture epidural hematoma, or infection. And you can see here at L5S1, there's a large disc herniation compressing the cauda equina. So the history, things you want to ask about are incontinence, and that's overflow incontinence. So whether they can feel their bladder is full, whether they have the same urgency to pass urine, or whether that's depressed, whether they have urinary retention, progressive neurological deficits, or whether they have progressive weakness in their legs, or saddle anesthesia. When you wipe yourself, do you feel numb around your bottom? When you pass urine, does it feel normal or does it feel numb? And for men, are you still able to get erections? If they have bilateral leg pain, that may be cauda equina, but there could be other causes. The most important history features are the ones there: incontinence, retention, deficit, and anesthesia. They have weakness, they have loss of anal tone, and they have saddle numbness when it's severe, and that's the light touch and pinprick. And the management is urgent imaging and decompression if appropriate. And saddle anesthesia is S1, S2, S3, just around the perianal region. So decreased rectal tone is a late finding, so we just have to be cognizant of it. The diagnosis is difficult and a low index of suspicion is appropriate. And I tell the registrars, you have to scan normal people to pick up cauda equina. If you're scanning all the patients, or if all your scans are cauda equina, then you're missing some. So referring people who you have suspicion of is appropriate if you're worried. So that's adult back pain, and with my pediatric hat on, I just wanted to mention pediatric back pain. So back pain in children is more common than previously thought, and having back pain as a child is a risk factor for developing back pain in adulthood. The incidence of low back pain increases with age from 1% at 7 years to 6% at 10 years to up to 20% at 14 years. And it's associated with physical activity, and the association is a U-shaped association. So those who partake in no activity have higher incidence of back pain, moderate activity low, and those who partake in a lot of physical activity have a higher incidence of back pain. So I see that in my practice with young girls that are heavy dancers or gymnasts. They do dancing 4 or 5 times a week. They come in with back pain. Girls are more likely to have low back pain, children going through the growth acceleration or with a family history of back pain. And families with psychosocial stresses can sometimes manifest as back pain. The differential for back pain in children is non-specific, not surprisingly. Spondylolysis or spondylolisthesis, and I'll come to that. Apophyseal ring fractures, so around the disc in the spine, there is where the bone grows from, and that can sometimes pull off. And that can avulse within the spinal canal, and that can push on one of the spinal nerves and can present with radiculopathy, and similar to a disc herniation presentation in adults. Sherman's disease or Sherman's kyphosis, which is an idiopathic kyphosis of the thoracic spine. They can get an achy pain in the thoracolumbar spine. And scoliosis was often thought not to be associated with back pain, but recent studies have shown that they have a twofold increase in back pain compared to a normal population. And of course, you can't forget inflammatory causes, infection, and tumors. So what is spondylolysis or spondylolisthesis? So lysis means fracture, listhesis means slip. And that is the fracture occurs in the pars intraarticularis, which is the blue box there on the diagram. And if I show you on a model, that is this area here between, this is looking at the side profile between the 2 joints of the spine. So things that can cause that to fracture in young athletes is anything that can cause hyperextension, because hyperextension kind of puts a nutcracker effect on that bit of bone. So gymnasts who do a lot of hyperextension, weightlifters, fast bowlers, when they're running in for the run-up, they hyperextend the spine, or rowers as well when they're pulling back. So those are the athletic children who are at risk for this. So an athletic children with low back pain could have a spondylolysis or spondylolisthesis. It most commonly occurs at L4 or L5, and it slips. So a spondylolisthesis, it slips when they have bilateral pars fractures. And when it slips, they can also get leg pain or L5 radiculopathy. And this is just a fracture in the pars on CT scan. And this is a spondylolisthesis. So you can see L5 slipping on S1 there. So the history in pediatric back pain is the general principles of history for any musculoskeletal condition. You want to characterize the pain, exclude inflammatory or malignant conditions. So morning stiffness or pain improved with activity, night pain or weight loss. Exclude red flags, which are the same. And then interested in family history, especially for inflammatory conditions and scoliosis. The examination, you're going to look at their posture, specifically looking at their shoulders and the alignment for scoliosis, tenderness and neurological examination. And then you have the stalk test for spondylolysis, where you ask the child to stand on one leg and hyperextend their back and see if that aggravates their back pain. So that's looking for a spondylolysis at L5S1. In investigations, x-rays if you're concerned or more than 8 weeks. Most of these kids will respond to conservative management. The evidence base for management of pediatric back pain is poor. Physiotherapy can help. Medications are the same as what you'd use in adults, but at pediatric doses, of course. And you'd refer if you're concerned if they have a spinal deformity or if they have a spondylolysis or a spondylolisthesis. So we've talked about back pain. So those are the non-surgical problems generally. And now the surgical problems in spine, which most of the time don't even come to surgery, but that can be helped with surgery. So we're going to talk about lumbar radiculopathy. So radiculopathy is often referred to as sciatica or brachyalgia if it's in the arm. It's pain in a single nerve distribution. It can be caused by a slipped disc or a spondylolisthesis. When the vertebrae slip, you can also get neural compression and radiculopathy. Most of them resolve with time, and the pain is due to sensitization of the nerve as well as neural compression. So even when I remove the compression or when the compression is removed or resolved, they may still have some pain in that distribution because the nerve is sensitized, and that sensitization can take a year or so to resolve. So in the history with someone with radiculopathy, what I want to know is, where is the pain? Is it in the back or is it in the leg? And how much of it is in the back versus how much of it is in the leg? Is it mostly leg dominant or is it mostly back dominant? Where does it go in the leg? And I spend a lot of time focusing specifically on where the pain goes in the leg. Does it go below the knee? If it doesn't go below the knee, it's as if it's on the posterior aspect of the thigh, then it's unlikely to be radicular. Where do they get numbness, tingling, and do they have any weakness? Do they find their foot catching on the carpet? Do they find their foot slapping on the floor, suggesting maybe they might have a foot drop? When did it start? Is it worse with coughing and sneezing? And do they have any symptoms of hip or groin pain, which might suggest that it's actually hip arthritis? One thing that I wanted to touch on is nerve root signatures. So dermatome or myotome. So dermatome is a single area of skin supplied by the nerve, and myotome is a group of muscles supplied by the nerve. So L2 radiculopathy is due to L1-2 disc, and you get groin pain with it. And that's due to hip arthritis. Can be hip arthritis. L3 radiculopathy is due to L2-3 disc herniation. And that gives you anterior thigh pain to the knee. So pain that doesn't go below the knee. And that can be, the differential would be knee pathology. So L2 and L3 radicular pain doesn't go below the knee, but it's on the anterior thigh. Knee, pain that goes to the posterior thigh that doesn't go below the knee, it generally isn't radicular, it's referred from the back. So the L4 nerve, so these are the most common nerve roots that get affected. That's an L3-4 disc, and this pain goes down the anterolateral thigh to the anterior knee. And the key thing for me that draws my eye or my ear to L4 is anterior shin pain. They get weakness in dorsiflexion. They lose sensation on the medial aspect of their ankle, and they can lose their patellar reflex. L5 radiculopathy is an L4-5 disc. And the key here is it goes down the lateral thigh, lateral knee, and the lateral leg to the ankle. What I didn't get taught at med school was that pain of the lateral thigh going to the lateral knee is L5 radiculopathy, because all the textbooks show you L5 as just being the lateral calf. And it can also go to the anterior foot as in that diagram. They get weakness in EHL, but also the abductors, they can walk with a tridombic gait. They get disturbed sensation in the first dorsal web space, and there's no L5 reflex. S1 nerve root is the L5-S1 disc. They get pain in the posterior thigh, knee, leg and ankle. So it's all posterior, all going below the knee. They get numbness on the sole of their foot. They lose their Achilles reflex or their plantar reflex, and they get weakness with toe off. But don't forget somatic and referred pain. So pain arising from the facet joints can refer down the leg too. So this is a study from the 70s where the investigators actually injected the L3, 4, 4, 5, and 5-1 facet joints. And they found that in normal people, they got the referral pattern on the left side. So very sporadic referral pattern. But in symptomatic patients with pain, that it can actually mimic an S1 radiculopathy. And the sacroiliac joint is the same thing. So this was a patient I saw in clinic a few days ago. They have arthritis of their right sacroiliac joint, and they were referred to me as the S1 radiculopathy. And the sacroiliac joint referral pattern, as you can see in that schematic, can refer it and confuse anyone that it's S1 radiculopathy. So don't forget about those causes of pain. So the examination consists of a neurological exam. So if they have a foot drop, you're thinking of an L4-5 disc. If they have loss of an ankle jerk or plantar flexion weakness, you're thinking of a L5-S1 disc. Straight leg raise, it's positive. It's if they get reproduction of pain below the knee, so pain down the leg below the knee at 30 degrees. And a cross straight leg raise test is when you raise the other leg and they get pain down the symptomatic leg. And that's often more specific for a disc herniation. Femoral stretch test for an L1 or L2 disc herniation. And the slump test is where you get someone seated, you get them to slump their spine forward and you extend the affected leg, and that should aggravate the pain. And that's the test that I most commonly use in my practice. And you can use these tests in combination to improve your diagnostic accuracy. And that comes from a Cochrane review in 2010. The imaging modalities in primary care are often limited. The x-rays are often non-specific. They don't really give you an answer unless they have a listhesis or a slipping of the bone causing the pain. But in Auckland, I understand the GPs have a MRI protocol where they can refer some patients with clear radicular symptoms for an MRI. So when appropriate, early MRI can be useful. So management, again, most of this is non-operative. So simple analgesics, avoiding opioids, minimizing tramadol. Oral steroids was a lot that we used it a lot in fellowship, but an article in JAMA 2015 or RCT showed that prednisone really didn't affect pain and only provided modest improvement in function. Gabapentin, something that I prescribe a lot, but when I looked at the evidence, I found that the evidence is poor. Canadian Medical Association Journal 2018 meta-analysis, moderate to high quality evidence that these anticonvulsives are not effective. And associated with adverse events. Again, this doesn't mean that it's not useful in everyone, but just use it with caution. And when should you refer? Well, radiculopathy, severe refractory pain, not responding to non-operative measures and interfering with work and function. So generally at 6 weeks, or could be earlier if they're in a lot of pain. Acute weakness, so a foot drop or plantar flexion weakness, failure of medical management. And the management for me is injections or surgery. If I look at the evidence for injections, so epidural corticosteroid injections, another Cochrane review, when they compared to placebo, surprise, surprise, very low to moderate evidence. The evidence in my field is not very strong. And the authors really sat on the fence, probably slightly reduced leg pain and disability at 2 weeks to 3 months. So, they may get a short-term relief, but this short-term relief may not be considered clinically important. And I explain it to patients as it helps them through the recovery. So if they're in the early phase, if they're within 3 months and they still have pain, maybe the steroid might help them through their phase of pain where they're going to get better by themselves and help them function better, but it may not be the final treatment for some patients. And those patients may come to a microscopic discectomy, and that's really considered after 6 weeks. And if you look at the long-term studies, the SPORT trial, compared to non-operative, there was a greater improvement in pain, bothersomeness from the leg pain, and patient satisfaction at 4 to 8 years when they compared to a non-operative group. If we look at radiculopathy in the neck, so the history is similar to lumbar radiculopathy. You want to know where the pain is in the neck or the arm, where in the arm, be really specific where the pain is in the arm. Is it going into the trapezius? Is it going down the arm? Or is it in the shoulder? Is it aggravated by neck position? Extension in some people really aggravates cervical radiculopathy. And numbness and tingling. Where is the numbness and tingling? Is it coming down the arm or is it coming up the arm? There are a lot of confusing things in the neck. It can be the shoulder, but it can also be the peripheral nerves. And you have to try or differentiate between whether it's a peripheral neuropathy. And then, of course, we have all these somatic referral patterns from abdominal causes, whether it's pancreatic disease, gallbladder, pancreas tumors. It can really be a challenge. And the last thing is you have to look out for symptoms of myelopathy, whether they have balance issues or dysfunction of fine motor skills, because that's more of an urgent problem that you want to get dealt to. So if we look at the nerve root signatures, the C5 nerve roots, the C4-5 disc, they get shoulder pain down to the elbow, not below the elbow. They get weakness in biceps and deltoid, and they get altered sensation along the lateral arm. They lose their biceps reflex if severe. C6 nerve root, they get pain down the lateral arm and the lateral forearm to the index finger and the thumb. And these diagrams often miss it. The C6, of course, is here, but they also get pain down the lateral shoulder. They get weakness in biceps and wrist extension. They get sensory disturbance in their thumb and their index finger, and they can lose their brachioradialis reflex. The C7 nerve root is often maligned as just shoulder pain or scapular pain, but patients complain of severe periscapular pain, right at the back of the scapula, radiating down the posterior aspect of their forearm, the posterior aspect of their arm, and into the middle finger. So pain here, periscapular, down the back of the arm or the back of the forearm makes me think it's a C7 nerve root. And this is really often missed, the C7 radiculopathy. They get weakness in wrist extension and finger extension. They lose sensation in their long finger and they lose their triceps reflex. C8 radiculopathy, that's the thing that the C8 comes down the medial forearm, a medial arm and medial forearm. They get sensory disturbance in the ulnar digits. They get weakness in hand intrinsics and finger flexors. And this is what's going to confuse a lot of people with ulnar neuropathy. And there's no C8 reflex. T1 reflex is medial arm pain to the elbow, T1 radiculopathy, sorry, medial arm pain to the elbow. This is not very common. They get weakness in intrinsics, and this is also the Pancoast tumor or upper lung malignancy invading into the brachial plexus. Examination is a standard neurological exam. The Sperling's test, so that's when someone has radiculopathy and you want to confirm it, you extend, laterally flex, and provide an axial, laterally flex ipsilaterally and provide an axial compression, and this aggravates the symptoms. Shoulder abduction shouldn't aggravate cervical radiculopathy. It actually relieves the pain. Patients find that having their arm above their shoulder, if they have radicular pain, is better, but that is not what patients with shoulder problems want. They want their arm by their side. So that's how you differentiate. One of the ways to differentiate between shoulder pain and radicular symptoms. The shoulder exam, and consider a peripheral nerve exam. Shoulder pain classically is dull and achy, pain with overhead activities associated with stiffness, and they don't like to lie on their shoulder. But it can be difficult, and this is a diagram. The red is referred pain from the neck, the facet joints or discs, and the blue is a referred pain from the shoulder. So it's really difficult to try and figure this out. And differentiating between peripheral neuropathy, you're going to look at the history. Carpal tunnel syndrome, that's commonly confused as a C6 or a C7 radiculopathy. But in carpal tunnel syndrome, they get hand symptoms. They wake up at night shaking the hand. Radicular patients don't have those signs. Carpal tunnel patients don't have triceps weakness or weakness with wrist extension. And patients with carpal tunnel syndrome will have normal forearm sensation or normal forearm. They won't have paresthesis in their forearm as a general rule. Cubital tunnel syndrome, so it's ulnar nerve compression behind the elbow, confuses people with C8 or T1 radiculopathy. So cubital tunnel patients don't have weakness in thumb flexion or thumb adduction because those are median nerve muscles. So no weakness with thumb abduction or finger flexion or thumb flexion. But they do have weakness in intrinsics, and they will have normal sensation on their medial arm generally. but it is difficult to differentiate between ulnar neuropathy, carpal tunnel syndrome, and cervical radiculopathy. Again, primary care imaging is limited and x-rays are not really specific. And the management is, again, non-operative. Most of these are non-operative. For the most part, cervical radiculopathy gets better by itself. Medical management is similar to lumbar radiculopathy. There's no strong evidence to support steroids. Steroid injections, again, low quality evidence. 50% of patients experience a 50% reduction for about 2 to 6 weeks. So again, I use it to get people through their worst symptoms as they were going to get better anyway. This just makes that time a bit more bearable for them. The treatment, you have multiple options. You have anterior versus posterior. You've got fusion and motion sparing. And most commonly, it's either an anterior cervical discectomy and fusion, which is the X-ray on the left, or a more newer technique is a disc replacement, which preserves motion. And a long-term outcome, it shows promising that it's not going to affect the adjacent levels with adjacent segment problems, which fusion does. Because once you fuse one level of the spine, it puts load, it can load the level above, and that level can wear out. And if that level is already symptomatic, it may predispose the patient to developing adjacent segment radiculopathy. So we're talking about spinal stenosis, lumbar spinal stenosis. So spinal stenosis is the imaging finding. So the top image is normal spine. The bottom image, you can't see the white, which is the cerebrospinal fluid. So that's spinal stenosis. Neurogenic claudication is the pattern of symptoms that people present with. So the pattern is older age group. They often have a long duration of symptoms. They're stoic. They get claudicant, cramping type pain in their buttock, thigh, and maybe even their back. And the key here is they must sit down for relief. So patients with vascular claudication, they get the claudication, they stop, they can keep standing and they get relief of the pain. But spinal claudication, patients have to sit down or lean forward and they can't bend backwards. They get numbness in the soles of the feet. They can get urinary retention when late. And it's important to differentiate between vascular claudication and spinal or neurogenic claudication. The examination is usually normal. They may have depressed reflexes and altered plantar sensation. Management for spinal stenosis, well, the options in primary care are limited. Physiotherapy really is of limited benefit and may help delay symptoms for a while. Epidural steroids, when they come to see me or a non-operative doctor, really don't help. A randomized controlled trial in New England in 2014 showed no benefit for steroid and local versus local alone at 6 weeks. So I don't use epidural steroids at all in my practice for spinal stenosis. And I offer patient surgery for moderate to severe symptoms when they have functional limitation from the spinal stenosis. And surgery can help improve their walking distance, their walking tolerance, and their standing time. So patients with spinal stenosis can't walk very far, and it's important to quantify that, and they can't stand for very long. And decompressing the stenosis can help with that. So when should you refer these patients? Well, when they have functional limitation or impaired quality of life, when they have weakness or numbness. It's an important clinical sign, but it may not improve after surgery. And oftentimes I have patients who are 85 who say, well, I'm too old for surgery. Well, a decompression operation, generally, if they're not too unwell, it's not a big operation. So greater than 80 years of age in itself is not a contraindication to surgery. Most of the time, if there's no listhesis or slipping of the bones, it's a decompression operation, which is just removing the bone and the ligaments, compressing the nerves and providing space for the spinal nerves. Not often would you have to do a fusion. So cervical myelopathy is due to stenosis or narrowing in the cervical spine. And it's progressive spinal cord dysfunction secondary to spinal cord compression, and it's due to multiple things. As you get older, you get bulging of the discs, you get loss of vertebral disc height, you get buckling of the ligaments both in the front and the back of the spine, you get bony formation behind the vertebral bodies and the discs, and all of this can combine to compress the spinal cord. And it's important to be cognizant of it because delay in diagnosis can lead to poorer outcomes. Patients decline in a stepwise fashion, and they never really get back to the step that they declined from. So generally, if someone has myelopathy, it's important to intervene early to prevent deterioration. But again, it's hard because the symptoms develop insidiously, and differentiating between multiple sclerosis, ALS, and tumors is important. So patients with myelopathy have clumsy hands and disturbance in fine motor skills. So the questions I ask them is they have troubles putting on their buttons, for women putting on their earrings or their bracelet or their necklace, using the phone or using utensils or chopsticks. They can have leg weakness and leg stiffness. They can get shoulder pain or a dull ache in their arm, numbness in both of their hands, and unsteady gait and falls. In the examination, they're hyperreflexic, they can have clonus, and they can have an upgoing planters. A Romberg's test is important, so that tests for dorsal column dysfunction. You ask patients to stand with their hands by their side, their feet by their side, feet together, close their eyes, and you'll observe them wobbling if they have dorsal column dysfunction. I don't usually tap them. If they have bad myelopathy, you'll see it when you just ask them to close their eyes. They can't sense their place in space. Hoffman's test is another useful thing. This is a long, deep tendon reflex to the middle finger, where you flick the middle finger and they get a reciprocal contraction of the index and the thumb. And that suggests upper motor neuron dysfunction. When should you refer these patients? Well, you should have a low threshold for referring patients with myelopathy because this is spinal cord dysfunction. And the goal of surgery is to stop progression, so we want to intervene early. Patients can be functionally limited, and this CT scan shows that OPLL, you can see the bone at the back of the vertebral body compressing the spinal cord. Investigations, that should read cervical, erect cervical spine x-rays, and the treatment is decompressive surgery. And if I talk briefly about the surgical options for cervical stenosis, decompression only or laminectomy, which is just taking the bones off the back, is not something we do really at all because patients can get a post-laminectomy kyphosis. What we often do is a laminectomy infusion where we take the bones off the back and we fuse the spine so they get something like this. Or more commonly, a laminoplasty. So laminoplasty meaning mold, lamino meaning the lamina, where we cut one side all the way through and the other side just on the outer cortex and bend the bone over and hold it with some plates to give space to the spinal cord. And that looks like that on the x-ray, and that preserves motion as well. So it's a non-fusion motion preserving operation. It's generally well tolerated, but in some instances, the only option is a fusion operation. So we've talked about radiculopathy, which is nerve root compression, stenosis, which is compression of the spinal canal, whether it's in the lumbar spine or the neck. And lastly, I just want to talk about spinal deformity. So spinal deformity can occur in adults and children. So in children, it's most commonly scoliosis. So scoliosis is curvature of the spine, and it's a three-dimensional problem. What we're often focused on is the coronal or the front-on curvature, but they also get a rotational problem, and they have problem with a lack of kyphosis. So they don't have the normal thoracic hump that everyone else does. And the definition is a coronal curvature greater than 10 degrees. Adolescent idiopathic is the most common cause of scoliosis and the most common scoliosis that I treat. There's a large genetic component, but we haven't been able to identify a gene, and it affects girls a lot more than boys. Important things in the history are when did menses start? Because girls grow most rapidly before the onset of their period, where they are in their growth, if there's a family history of scoliosis, is there pain? Scoliosis can be secondary to disc herniations or spinal tumors or anything that causes pain in the spine. The child's spine is incredibly plastic, and they'll develop a scoliosis to offload the nerve which is being compressed. And progression, is it progressing rapidly or slowly? How do they notice it? Has it got a lot worse? The first thing you want to check in the examination is, do they really have scoliosis? So the best test for that is bending them forward. If they have a rotational deformity, as you see on the right, if they have a bump on their thorax or their flank, then they have a real scoliosis. And a right-sided bump is all right. So right is all right. A left-sided bump is something you have to worry about because there could be an underlying neurological cause. So in this schematic on the right, a right-sided bump is generally an idiopathic scoliosis. And do they have a neurological cause? So then you're looking at upper motor neuron signs. So you're looking at their reflexes, you're looking for clonus. And sorry, I just wanted to show you why the rib gets pushed up, because the rotation, when the vertebral body rotates, it pushes the rib up. And looking for a neurological cause, looking at their reflexes, so hyperreflexia, clonus, upgoing plantars, and also the abdominal reflexes. So you lie the child flat on the bed with their arms by their side and relax them as much as possible. And you're stroking towards the umbilicus in all 4 quadrants, and the umbilicus should move. If one side moves and the other side doesn't, that's an asymmetrical abdominal reflex, and that should concern you that they may have an underlying thoracic spinal cord issue. So when should you refer? Well, almost always for scoliosis. And the thing that you should ask for is whole spine stitched PA and lateral x-rays. The key is stitched. What I often get is whole spine x-rays, and that's just the patients come with neck, thoracic, and low back. And that is not really useful to us as spine surgeons, because it often undercauses scoliosis. So we get this whole spine stitched x-rays, and that unfortunately exposes the child to more radiation. So whole spine stitched PA and lateral x-rays. PA, because the beam comes from the back to the front, so the dose of radiation to the young woman's breast, so the young girl's breast, is less. So whole spine stitched PA and lateral x-rays. So if I want to briefly touch on management, so management depends on curve size. If it's less than 25 degrees, we're going to observe it. If it's greater than 25 but less than 40, in my practice, I brace these children. And the key to bracing is 18 hours a day, and then it stops curve progression. The curve is not going to get better. What they have when they go into the brace is the best that they're going to achieve. And as long as it's less than 40, they're going to lead a normal life, and they're going to avoid an operation. Surgery is generally indicated greater than 45 degrees, and the options are fusion, as I showed you in the previous x-ray, or a newer technique, which is vertebral body tethering, which is a motion preserving type operation. It's internal brace. It's still very new and novel and used in only certain indications. But patients who have surgery for scoliosis, they lead normal lives compared to their peers. Their rate of back pain is the same as their peers who haven't had surgery. Their occupation chances are the same, except they may not be heavy manual laborers. And for girls, what I often get from mothers is whether or not they're going to be able to have children, and their ability to have children and raise a family is the same as to their peers who haven't had scoliosis. So they have normal life trajectories after spinal fusion for scoliosis. So finally, in the last 5 minutes, adult spine deformity. So this is a growing area for us as spine surgeons. And adult spine deformity is a degenerative deformity in the adult spine, and it's either a kyphosis, scoliosis, or iatrogenic flat back. So someone that's had a fusion that may have failed or may have not been fused in appropriate alignment, they've developed an adult spine deformity. It's increasing in prevalence with increasing age. So it's you see it in about 6% of adults over the age of 50. And these patients have significant disability. It's often underrepresented. So they have poor quality of life measures when compared to their normal peers or their normal counterparts. The burden that they experience from adult spinal deformity is similar to that experienced for patients with congestive heart failure or diabetes. So these patients have significant disease burden, and they also are affected psychologically, and they have poorer mental health scores. So what happens in adult spinal deformity is they lose their lumbar lordosis, and when they lose their lumbar lordosis, they compensate. So the key is they want to maintain horizontal gaze. Sorry, I wanted to try and annotate this, but so they lose horizontal gaze. And the whole goal of life is to maintain our eyes looking forward. So if you lose lumbar lordosis, if your lumbar spine starts to look like this, you're looking down. So how can you overcome looking down? You move your pelvis, so you rotate your pelvis forward. You work these muscles at the back of your spine really hard to try and overcome that degenerative disease in your lower back. So you try and lordose your lumbar spine, but you can't. So then you work the thoracic spine muscles to try and lordoze your thoracic spine to pull yourself up to look, and that eventually, that compensation is eventually exhausts. Then you're going to extend your neck and extend your head up to keep looking up, and then that exhausts. Then you're going to drop your hips, you're going to flex your hips and flex your knees. So all of that gives them that posture where they come into your office, they have flexed hips, flexed knees, and they're really trying to look forward, but they can't, they're stooped forward. And that's a really inefficient mechanism or inefficient way of standing, an inefficient gait. So they fatigue really easily, they really quickly and really easily. They're using their muscles to keep themselves looking up, where for most of us, we can stand straight and all the load is being passed through the bones and the ligaments. So there's no active part in standing up straight. But for patients with adult spine deformity, they are using the muscles all the time. So they have back pain and early fatiguing when they walk. So how do you assess these patients? Well, they have a heterogeneous presentation. They have back pain, fatiguing, difficulty with activities of daily living. They can have associated spinal stenosis and neurogenic claudication. They're disabled by it. And when you examine them, you want to look at their posture, their horizontal gaze, and examine their neurology. Again, you're going to start with non-operative management, physiotherapy, and following the same principles of low back pain management. But if they fail, then you should refer them for assessment. There is something that can be done for appropriate patients. We can provide help. So just because they have a scoliosis and they're 65 or a kyphosis and they're 65 doesn't mean that nothing can be done. The surgery is significant for these patients. So the risk profile is high, but at 1 year, if you ask the patients undergoing adult spine deformity surgery whether or not they would have the surgery again, despite going through complications, some of them quite big, patients say they would have it again based on what they were like before to what they are afterwards. So surgery does improve pain, disability, and health-related quality of life outcomes. So somehow I've managed to stick absolutely to time. So in summary, non-specific back pain is best managed with education and therapy, physical therapy. I refer a lot to non-operative musculoskeletal doctors for the patients that I can't help with back pain. Radiculopathy should be referred after 6 weeks or earlier if you're worried about weakness, or if someone really isn't coping with severe radiculopathy. Stenosis, whether that's in the neck or the back, has limited management options in primary care, and you should refer them if you have reached your end of how you can manage these patients. And generally, spinal deformity always should be referred, always in pediatrics, and for the most part in adults if they're medically fit. There is something we can do for adults with spinal deformity. So thank you very much for the time. This is just a photo of New York City. I think this was sunrise. I was there when COVID initially got to New York, and I think this was after the first wave, a peaceful sunrise in Central Park. So some solace in what was a crazy time. So thank you very much for your attention, and very happy to take any questions.
Thank you, Anand. That was a fantastic presentation. We do have a few questions that have come through. If I can take you back to our initial start with non-specific back pain, you talked about paracetamol and anti-inflammatories being your initial trial, but no real evidence behind the paracetamol on your systematic review.
Yeah.
There's a question of whether there were any subgroup analysis within that systematic review. Were there any, was there any benefit shown for some people? Because it appears clinically that some people do get benefit from paracetamol.
That's a really good question. It's not something that I can remember, but I can provide the study to you guys to share with anyone that's interested. It's not something that I know off the top of my head. I'm sorry. Okay.
And with that, when you have people who are contraindicated to using anti-inflammatories, the paracetamol, likely isn't going to work. Do you consider using prednisone for that non-specific back pain?
I very rarely have used prednisone for non-specific back pain. Paracetamol, the population doesn't work, but if someone can't take non-steroidals, I'm not going to not prescribe paracetamol. but for the most part, like the 20-year-old male or the 40-year-old woman with back pain, that's when the paracetamol is not going to work. So I haven't, in answer to the question, I haven't used prednisone very much for back pain. I still use it time to time for really severe radiculopathy. I do give them the 15-day course, or someone that has post-operative radiculopathy, which is can occur sometimes after spine surgery. I will give them a 15-day course of prednisone for radicular pain.
And how do you prescribe that course?
It is quite a high dose, so I don't want anyone to get too scared, but it's in my practice management, but based on that paper, it was, I think, 60 milligrams for 5 days, 40 milligrams for 5 days, and 20 milligrams for 5 days. But again, I can provide that paper to share. That's what I've based my practice on, that paper.
And that's for the radiculopathy presentation.
The radiculopathy, correct.
Yeah. Thank you. Someone has asked a little bit more around the benefit of physiotherapy, and whether there's a benefit just to encourage people to be doing exercise in general and keeping on moving, and whether there's a official benefit behind physical therapy as a process.
I really think there is. And the trouble with those meta-analyses is that the studies, when, like always, the overarching theme was very low to moderate evidence. So you're coming from a very low evidence base and you're going to get kind of results which should guide practice, but also you take with a pinch of salt because the evidence underlying them is low. So I still think there's a lot of value to physiotherapy, exactly to keep moving. And I'm very prescriptive in what I ask some physios to do. There are a lot of there are a lot of really good physios that do great therapy, but there are also some not so good ones. And I always ask the patients what they're getting done. And if it's not exercises, if they're going once a week and getting a massage and going home, that's not going to help them. It's a guided rehab. And in the same breath, you know, if someone asks me about chiropractor or osteopathy or acupuncture, I say, look, there's benefit for some people. I don't refer people because I don't really know, understand what they do. But if you have someone that you want to see, by all means, go see them and make that judgment for yourself. There's low harm, and you may find benefit. And I have patients that come in that swear by their chiropractor or osteopath or acupuncturist. So I don't completely disregard any of it. I just use it judiciously.
And perhaps the education of the patient of having exercises rather than as an expectation, rather 100%. Than just the massage.
Yeah, 100%. And also, I think what physiotherapy helps with is getting people down that recovery track, not that fear avoidance cycle. I had a patient in here a couple of days ago or yesterday who was clearly in the fear avoidance behavior. He was a builder. He had back surgery, unfortunately, and then the second surgery didn't go so well. And then he was, I didn't do the surgery, thankfully, but he was so anxious about the pain. He wouldn't get out of bed. And he was clearly in that cycle. And I just brought it up, and he was a very reasonable guy. And I showed it to him, and it's like, look, sir, like you're in this cycle. And it's like, oh, wow, yeah, I am. And I can't help you as a spine surgeon, but, you know, psychiatry, psychology, therapy, and just keep moving. Moving is not going to hurt you. Your spine is absolutely normal. And hopefully that helps some people.
There's a question here. What is the evidence for inversion traction for disc protrusions?
So I don't know that answer. I see my musculoskeletal colleagues prescribing that a lot. And that's why I work so closely with a few MSK doctors, because they are really up to play with all the non-operative management. And so if someone has something that is generally non-operative, and I don't think that they're going to get better in a short period of time, I have no hesitation in referring them to musculoskeletal doctors, and that's they provide a really great service. I think, again, the evidence is probably going to be very low to moderate for inversion therapy and traction therapy to that same extent for neck pain. You're going to have some people that find relief and some people that don't. The harm is going to be really low, and the cost is borne by the patient. So if they want to try it and undertake that financial cost, then I don't discourage people from doing things if I don't think the harm is there. So if someone says, do you think inversion therapies work? I say, well, I don't know. It probably doesn't harm, but it's really expensive. If you want to try it, by all means.
Yep. Okay. There's a question about your thoughts on transforaminal CT guided steroid injections. Someone had a patient who got great relief from that versus instead of the ultrasound guided steroid injections. Is there a difference?
So there's 3 types: ultrasound guided, which would be mostly done in the office by, I think, pain doctors and musculoskeletal doctors, and they would be targeting the facet joints to see if those are a cause of pain. And then you've got fluoroscopic or II guided nerve root injections or CT guided. So all the nerve root injections that I order are all CT guided. And so you get an image back from the radiologist where you see the dye going either in the nerve root sheath or around the nerve root, so you know exactly where the steroid and local anesthetic has been injected. In the neck, I think there is always a risk of a significant complication, whether that is steroid or local injected into the spinal cord. With fluoroscopic or II guided injections. So all neck injections for me are always CT guided and by the radiologists. In the States where I train, some pain doctors would do neck injections themselves. And in one of the units I worked at, once a year, we would get someone who had a cervical spinal cord injury from a fluoroscopic guided injection. Now, the incidence of that probably for all the injections is really, really low, but the morbidity is huge. So I don't think there's anyone in Auckland that does fluoroscopic guided neck injections. It'll all be CT.
There's a question, can you comment on ultrasound guided deep truncal muscle retraining for low back pain? So, heard it is a new but reasonably effective treatment in sports medicine.
I don't know. I think maybe the next spine talk might have to be a non-operative MSK doctor. I thought about running this session with him, but we didn't. Our schedules didn't align. But certainly that's why I refer to them so much, because they know all about that.
Okay. There's a couple of questions. One, when you mentioned there was a fracture could be easily missed with ankylosing spondylitis, and the question is it that you should have a higher suspicion for fracture in the first place, or is it just that they need more advanced imaging to be able to see a traumatic or pathological fracture?
It's both, actually. If someone with ankylosing spondylitis has had a reasonable trauma and they're complaining of pain, don't discount it. X-ray will often miss it because the X-ray is full of bone. So they need a CT or sometimes even an MRI scan to look for the fracture. So they should be referred if you're worried.
In Auckland, you mentioned that there is the GP training to refer for MRIs for certain conditions. And I know there's guidance around when that is appropriate. For the rest of our audience, are you able to give us a little rundown about when that would be appropriate from your point of view?
From my point, so I don't know the exact guidelines, but from my point of view, if someone has really clear ridiculous symptoms and it hasn't got better after 6 weeks, that's when they are in for an MRI. So that's symptoms that fit clearly into one of those patterns where it's a S1 down the back of their thigh, back of their calf, L5 down the side of their thigh, side of their calf, or L4, going to the front of their shin. That's someone who would speed up the process if you're referring it to a surgeon or a non-operative doctor or a sports doctor, because then they have the information in front of them. The patient doesn't have to wait another 2 weeks and they can be sent almost straight away for their injection. And most of the referrals I've had for patients that have had the GP to MRI on that pathway have been really massive disc herniation. So, whatever the guidelines that have been, given to the GPs are obviously really good because they've been used appropriately. But exactly the guidelines, I'm not too sure what they are.
And would you always do X-rays beforehand, even in young people?
So for me, I always do X-ray. I think the answer is yes, based on guidelines. But I do X-rays in young people for who I'm thinking I'm going to operate on for two reasons. I want to make sure they don't have any lumbosacral abnormality in counting when I'm doing surgery, and I want to make sure they have no instability in their spine. So that's why I do X-rays. For me, I think in primary care, you're doing X-rays to look for other things, right? Bad things. So that's why X-rays are important for any bony pathology.
Where do you experience the numbness found in spinal stenosis?
So generally they have plantar numbness on the soles of their feet. And that's difficult, you know, in primary care because you're thinking peripheral neuropathy as well. And the plantar numbness after surgery generally doesn't get better, or it takes a long time to get it better. So that's what I spend a lot of time explaining to patients, that numbness that doesn't improve after surgery, or may not improve after surgery. If it does, it takes a long time, but it's generally plantar numbness, so numbness in the sole of the feet.
Thank you. Can you explain your pediatric scoliosis talk, which was really interesting? I think we'll always remember right is all right versus the left side. Can you explain why the left side, you said it points to a more neurological cause. Why is that always on the left?
So it's not always on the left, but it's just more common on the left.
Okay.
It's just so what we don't understand of scoliosis is why it happens. But for the most part, idiopathic scoliosis, the tight annulus and the tight discs in the vertebral bodies are abnormal on the left side, so on the concavity. So on the right side is pushed up as the bodies rotate, and that's just the opposite in neurological scoliosis. I saw a kid the other day who I referred for an MRI scan with a right-sided scoliosis. And he actually had a large syrinx, so dilation of the central spinal canal, and a Carey malformation, so herniation of his cerebellum through his foramen magnum. And that right-sided scoliosis in Maori and Pacific Island children, there is a slightly higher proportion of that being from a neurological cause. So at Starship, and I think in New Zealand in general, any child that's coming scoliosis of a surgical magnitude is getting an MRI scan to exclude an underlying neurological cause. In the States, there are a lot of really big pediatric hospitals that won't MRI scan kids before scoliosis surgery if it's a right-sided curve. So that's how much right-sided is okay, that spine surgeons are willing to operate on kids without doing an MRI scan. But in New Zealand, we don't do that because of the risk that in certain patients, we may be missing something, and that could have disastrous consequences when we correct the scoliosis.
So maybe right is mostly all right.
Right is, yeah. I mean, in primary care, right is all right.
Yeah.
You know, they're all right. Right is all right, except if they're of certain ethnicities.
There's a question here. When you brace for pediatric scoliosis, do you use rigid bracing or a dynamic movement orthosis suit?
So those don't work. So that's DMO suits is something that was sold to patients. I'm not sure how. I think it really was popular when I was a registrar, and there's some fanatical families about it, but the evidence doesn't support it. So for my bracing, I use rigid three-dimensional molded braces, and those braces have 3 points. What's a three-dimensional thing? It's trying to rotate the spine back. And what the brace does, it actually corrects the spine. So you put the brace on, you take an X-ray, you want to see at least a 50% correction in the scoliosis in brace. But that's not correcting the spine, it's just holding it straight while the spine grows. So rigid full-time bracing. So I tell kids that they have to wear the brace all day, pretty much 18 hours a day. They can take it off to do activities after school and shower, but they must wear it when they're sleeping. Kids grow the most when they're sleeping, so it's really important that they wear it when they're sleeping, and they have to wear it for 18 hours a day. Compliance is the biggest issue with bracing. If someone really wants to avoid an operation, they're going to be compliant with bracing. If they're not bought into it, they're not going to be compliant. So compliance, 18 hours a day is the most important. And the numbers needed to treat to prevent one operation for bracing is 3 if inappropriately braced in the appropriate population. So in my hands, in my practice, I do brace children, but it does have limitations and implications. The braces now are a lot better than they were 10, 15 years ago. You can wear them under clothes. They're not really noticeable. They're light and they have cutouts, so they're breathable. But if you're bracing someone early, say at age 11, they're going to have to wear that until they're skeletally mature. So that's, 2.5 years. So that's a lot of their childhood that they were, even longer, a lot of their childhood that they're wearing a brace. So that's something you have to be conscious of as well. So those really large curves in someone who's young. So if someone is 11, a boy is 11 and he has a 35-degree curve, that's very likely going to be surgical. So I may not brace it. It's a discussion between the family and where I think the curve's going to go.
Okay, I think we're out of time there, Anand, but that was a fantastic talk, and I know everyone's really enjoyed it. So thank you to the audience, and thank you very much again for coming and
Absolutely.
speaking to us.
Thank you, Helen. Thanks, everybody.